Right. Sent over a few of Jim's presentations this week. Some are on just general differential diagnosis. There's a couple cover some of the cervical conditions. Uh, those are good background information ones to have and kind of give you a sense of thought. Like for today, I sent out one on the EIS, essential condition scripts or illness scripts, as they kind of defined it. And what they are, again, it's kind of just a general way of framing information in our mind of what does the typical presentation of a case look like. Having the concept of what a typical case looks like helps us move through information quicker and better kind of set our evaluation process. Top document here, and this image can be a little bit hard to read nowadays because it's blurred because it's a JPEG image, but this is one of the classic ones where you can look at and see kind of what are the different conditions we may see and what are some of the key characteristics of them. We've gone through and I've outlined some, and I'm kind of working through some of a more of an expanded list in a way to think about it. And we'll work a little bit on that today, which is the document I sent in below. But a lot of what we do is we frame is framing in our mind, what does that typical condition look like? And we'll go through a couple of examples today on how to do it. Now, that said, is very few, again, not like everybody fits into it. When they do, it's great, it's easy, but not everyone will always fit cleanly into one of these conditions. As we said, is we can have somebody with a disc herniation, we can have somatic pain, but not referred pain. Yeah, Paul, this was sent by email. It's also, you can get to this document. It's in the first page in the Google pre-course sheets. It's in the prep section for this week. There. So again, that typical disc, the atypical disc, the chronic posterior lateral disc, which hasn't irritated or inflamed the nerve root, give you a different presentation. But your classic acute disc, it's good to understand what these look like, as well as we're looking at whiplash, and we're going to work on differentiating some of the whiplash post-concussive stuff and headaches and dizziness in future presentations. So we're going to cover it a little bit today, but again, you're not going to really do that a lot of justice breezing through it in a 4-minute conversation. We'll touch on it a bit, start to introduce those concepts. Oh, let me arrange this so I can read my desktop. Here. Around. All right, Kyle. Let's say I have a 35-year-old female who presents with neck pain, limited range of motion, limited ability to turn her neck. She was doing inversions in yoga the prior day. Pain is moderate to severe. She's had neck pain in the past, but nothing like this at present. Kyle, what would you be thinking in this case?
Well, I think that if she had some neck pain in the past, she's got some limited range of motion, ability to turn. Sounds like it's something new that she did. Um, I would think that she's got something local because she's not reporting anything traveling down her arm or into the periphery. So my biggest H1 right now would be something potentially segmental.
Okay. So how would you test that for segmental?
I would do my PIVMs and PAVMs.
Okay. All right, let me go back one step. What two questions would kind of help further kind of solidify that? So think about two questions first that you'd ask on this individual. If it was a segmental dysfunction.
Um, I would look for the quality.
Mhm. And how would you describe that quality?
Well, if I'm asking her to describe the quality, I'm looking to differentiate between um, something electrical, burning, numbness, tingling, anything of that
Okay.
nature, versus maybe a sharp or a kind of pain
She she tells you she has a kind of a dull numbness and tingling going down, extending past the elbow into the thumb.
into the thumb. Okay.
Mhm. What does that do? To
That
strengthen your hypothesis or weaken it?
weaken
Okay. Why so?
because the quality of the pain is not the same as a just simple referred pain. It's more of a electrical type of a presentation.
Mhm. So what does that lend you to think? What are you thinking there? Keeping your H1? Do you want to ask a few more questions with the biomechanical dysfunction?
Yeah. So if I'm looking less at that H1 and I'm leaning more in a different direction, I would be asking if she can reproduce her pain with specific movements.
Sure. First, let's go. What is your H2 now? What is your second hypothesis?
H2 would be a
Yeah, because you don't
C,
want to. Go ahead.
yeah, a potential C6, um, C6-7 potential like disc herniation.
Okay, good. And the reason why you want to have that is because if you just go asking blind questions, now you just start poking around the dark and it gets a little more confusing.
Right.
Being able to do a hypothesis testing kind of focuses you in like, okay, I was thinking this wasn't, biomechanical, but boy, I'm getting paresthesias now. So I'm going to rethink that and think, okay, I got something that's irritating a nerve. And what are two potential conditions you can think about that would irritate the nerve and give me neural symptoms?
You mean to like
Said disc herniation was one of them. What would be another thing that could potentially give me neuropathic symptoms? They're probably less likely in this individual.
less likely? Uh,
Yeah, at the age group, I'd put it a little less likely.
yeah, so like a lateral stenosis would be less like,
Yeah.
and
Yeah, I'd be thinking that'd be a little bit patient, maybe a little bit older, unless it's like an acute extension subluxation and they're hypermobile. There's something happened, but those would be the two that would be closest. That would give me that neural compression. So,
mhm,
what question? Let's go back to the question you would use now for disc herniation.
okay.
What would you expect your disc herniation patient to look like?
Well, I would expect movement into extension to potentially alleviate her symptoms, and movement into flexion to potentially exacerbate the symptoms.
Yeah, what would the range of motion quality generally look like?
If we're looking at an acute disc herniation, it would be limited multifunctionally,
Hmm.
accompanied by pain.
Yeah, and the pain quality is going to be moderate to severe. This is going to be very angry.
Yeah.
Your segmental dysfunction, sometimes in the acute case, if it's an acute one, can be more irritable. The pain can be more severe, but you're looking for like there's been a rapid change in her. Now she described that the pain came on, a little bit later on in a time. So what does that tell us about it as well? Does that seem reasonable with the disc herniation? The pain may onset like the next morning when she wakes up or later that night.
I would say that potentially I could see that if
Mhm.
she had something that she did to predispose it, and then
Mhm.
the herniation maybe didn't necessarily occur to the clinical level until she woke up the following morning, and that it could have led to some inflammation, which would have further increased her
Yeah.
symptom onset.
Mhm. Yeah. That's exactly kind of what you're looking for. And here we have again, you have two questions which are kind of consistent with, what we were looking at before with emotions and testing. What we would do is, as you alluded, our best test or, best test isn't really a good word for it. We're looking for tests that may have the best sensitivity and specificity. Any condition there helpful for ruling it in or helping rule it out. But here you're probably looking at Sperling's upper limb tension test and, definitely dermatome myotome reflex. If you read the general literature, they'll argue a little bit about the generalized clarity of dermatome myotome reflex, but for us, I think it's pretty clear when you have those things, you have a radiculopathy and neural irritation. How stressful was that column 1 to 10?
5, 6.
Oh, good. I'll push harder for the next one.
All right, it was definitely a 10.
Okay.
Did you see that I can't get access to that document?
Yeah, I apparently this is something I do stupidly sometimes there. So if you go in there and click it, I have my phone in my hand. I can, if you send me a request,
A request.
I will, yeah, you just have to ask request for access and I will go in and grant you access. I
Okay.
sometimes send the signal when it sends it out. It wants everyone, once that person puts a limit on them. So if I seem like
Gotcha.
I'm distracted for a second, it's me clicking the access button. Let's ruin Lindsay's day. A 62-year-old female who started having acute non-vertiginous dizziness. She took a Zumba class that morning. And I'm going to actually make it vertiginous dizziness. I'm going to take the non out. So a 62-year-old female started having acute vertiginous dizziness, and she took a Zumba class that morning. What are you thinking, Lindsay?
Um,
Take your time and just kind of put out what you think. Don't feel like you're being judged or rushed. And remember, I don't know is a great answer. I want to stress Kyle,
um,
not you.
well, my initial thought when I think of vertiginous dizziness is I think of
Mhm.
BPPV.
Yeah.
Um, but we're talking cervical here, so
Oh, don't let that fool you. Don't. It's a good thing. Don't. This is, I'm trying to. I'll ask trick questions later, but right now, the first thought was vertiginous. What's your H1?
um, I would go with BPPV.
Okay, cool.
I know it's not the right
Well,
answer though.
oh,
I
you
don't
don't
have
know
enough
that yet.
information in terms of like, is it
Yeah.
occurring if she's rolling over in bed or any of that information
Hmm.
at this point?
What a piece of information here would strengthen. There's another piece of information in here that would strengthen that this would probably be vertiginous dizziness. You're looking at this and you probably saw it, didn't think about it, but it was there.
Um, well, she did Zumba in the morning.
Hmm. So she had something was spinning.
Yeah,
What's her age?
she's 62.
What's the most common age that starts to set in?
I don't know
About
the answer to
60.
that.
Yeah, it's about 60.
Okay.
So, effectively, she's okay. She's 60 years old. She's having vertiginous dizziness, and she took a Zumba class where she was kind of spinning around. You know, those in the active, she was doing something that was odd, her age, and the type of dizziness that she has. Now, vertiginous dizziness is that, illusion of movement, or the room is spinning, or let's say, or I'm spinning. Non-vertiginous dizziness is like a disequilibrium or an unsteadiness, which can be due to a number of things. It can be medication, it could be something central that's driving it as well. It could be servergenic. It's going to give you non-vertiginous dizziness, generally speaking. So, and Lindsay, I know you're trying to figure out, okay, so cervical, of course, it must be cervical, but kind of to figure out the cervical dizziness, you got to kind of quantify, okay, this is vertiginous dizziness, and that's not typical of a cervical dizziness. So let me work my H1 for what may be the most common form of vertiginous dizziness. So BPPV. So if you think that this is BPPV, what is your next question or test?
Um, excuse me. I would test, well, typically with BPPV, the most common canal affected is the right posterior canal. So you could perform the Dix-Hallpike and test for that. But it would also be just asking the questions of when is it occurring and things like that.
Yeah, when she's changing positions in bed, she's okay for about 20 seconds or so. Then she feels like the dizziness comes on and it's strong for about 30 seconds to a minute, and then it abates. Does that strengthen or weaken your hypothesis?
It strengthens it.
Okay, good. What test would you use to kind of further to confirm it?
Um,
Keep rolling. You're on a tear, so just keep going.
I
Trust
would do the
yourself.
Dix Hall Pike.
Yeah. And let's say, for whatever reason, you want to rule out as a bias correction that it's coming from the cervical spine. What would you do then to rule out that this was okay? I'm pretty sure this is it. It's been positive there. I want to rule out the cervical spine. What could you do to rule it out for a cervigenic headache?
A cervicogenic headache.
What would that look like?
Um,
And you just start by describing what would the typical cervigenic headache patient look like, or how would that present? Because having that case in your mind helps you differentiate it.
okay. I haven't seen a ton of those, but in terms of a cervicogenic headache,
I think it's searching. What type of dizziness would it likely be?
non-vertiginous.
Yeah, I like to be non-vertiginous dizziness. So more of a disequilibrium thing. What would you expect then to find in the cervical spine?
Tightness through the paraspinals.
Yep. And most likely, which levels would be involved? I'll give you a choice, upper or lower.
Hmm. I would say upper, looking at the
Okay.
suboccipitals and everything too.
You would be correct. It's usually going to be driven like C3 to 12. Now, there can be some influences where something below causes a correction above it. So you can have a C1, C2 causing it, but there's maybe a driver at C6, C7 or somewhere else. That does happen. Saw a patient today where it can move C1 and correct thoracic spine, or you can kind of go back and forth between the two. But your innervation levels, the way they're run, and you're looking at influences through the trigeminal nucleus and into the central system, generally going to be your C3 and above is going to be your cervigenic headache influences. So I'm expecting to find something up in there in that region. And it should be a little trickier too. So 62 years old, we're probably gonna have some arthrosis up there, which we will find. But from the type of dizziness we have, we do it. But that's kind of like where we're working on is that idea that when you have these illness scripts in your mind of what is the typical case, like you're filtering out a bunch of different differentials without even realizing you're doing it because it didn't match the typical script in your mind, and you go to the most obvious. So what you did was right. You went to the most obvious and tested that first. Kyle did was great too. He went to his H1. His H1 didn't pan out. Then you just go to the H2 that makes the most sense, that fits the pattern that you're seeing. But when you don't have these clear patterns in your mind, we tend to kick around trying to get all the information and then make a decision. And it's a much harder way to come to a conclusion without a focused train of thought. Nicely done. Changes one here a little bit. Spong changes one. We're going to go. A 56-year-old female presents with recent history of somatic referred pain to the right upper extremity, into the elbow, and she has some somatic referral down into the right hand and forearm. Is not a paresthesia. What are you thinking, Paul?
Okay, so just the symptoms down into the right hand, I'm thinking probably more like referred pain versus radicular pain.
Hmm.
No acute onset. Yeah, so I guess I would say like with more referred pain, I'm thinking something more like segmental versus disc herniation being more Somatic pain at elbow to right somatic. Yeah, I would say with the somatic pain into the hand versus without it being like super specific, that is kind of pushed me away from like radicular type pain versus referred pain, just because it seems to be kind of like generalized. I would ask more specifics about the location of the pain into the hand.
Goes into the thumb and now it goes into the thumb. She's had it on and off for a while in the neck, but now it goes into the thumb and more in the index finger now more recently.
So thumb and index finger, I guess that would kind of start me thinking towards C6, C7 lower cervical spine. I would try to ask, get an idea of what are the specific activities that make it worse, or specific motions that make that worse.
Okay. Motion, I mean, her neck feels generally stiff. It is stiff when she bends it to the right side. The left side bending isn't much better. There's just slightly less grimacing. Rotation is probably about 80% full. Extension, again, there's a little bit of shearing at C5, C6 when she extends the ears over the shoulder. And flexion is kind of about 20% limited. It's just irritable at end range with no referral symptoms increased.
So none of the motions created any more referral?
Creates irritation, but you didn't necessarily see more referral.
Yeah, so I guess that's making me think again more like just like segmental joint dysfunction without anything that can recreate peripheral stuff.
Okay. Then what would you do next?
I would, let's see. I mean, I guess I would try to like assess the joint movements, check for like the muscles, see what's going on in the muscles around that area.
Yeah, what do you think the cause of this is? Let's talk a few causes. Let's get specific. Said joints. Which joints are you going to check?
I guess check cervical facet joints. I would guess what I would think that could cause this could be, I guess possible things that could cause this could be like some stenosis, foraminal stenosis possibly. I guess I would anticipate muscle tightness. I don't know that would be the cause of it.
Leave muscle tightness aside because it's kind of a different conversation. Even when we look at muscle tightness, we're going to talk about, then we have to get into what is the driver of the muscle tightness.
Sure.
Why do I have this muscle over lengthened? Why do I have this muscle facilitated? And then we're into scapular regions and head position. So you can put in muscle. But whenever I do muscle, it's like it's okay to have a muscle, but I never, and Eric will say the same thing. We'll never stop at muscle.
Sure.
If I see a muscle, then I'm thinking, why is this muscle like a guitar string out of tune? Is there too little tension? Is there too much tension? Where do I get it to be just right? But you can go in there. So lateral stenosis. What else? What other structures can give pain in the neck?
Discs.
Mhm.
What else? I mean, like the like ligaments, inert ligaments, if they're overstrained due to like excessive motion or lack of motion.
Yeah, like ligaments, dura, disc,
yeah.
muscles, facet joint. Maybe even just capsule there. If we put it, that'd be arthrosis. There's one thing missing in here. But K knows. Okay, what's missing from this list? I'll give you a hint. It's a joint.
Oh, uncovertebral joints.
There you
Yeah,
go.
there you go. You beat her to it. It's like Family Feud. Yeah, I may put just to get it on our radar screen because we'll talk a good bit about that at the course, and we'll start to palpate those. So I can spell it correctly while I'm here talking. There we go. Anchovertebral joint. So in your mind there, you just frame out, okay, what are the possible things that may be causing somatic pain that's referred into the arm? And these are things we'll go to. Okay, how would you test a facet joint? It's the same as the lumbar spine.
Yeah, I
Yeah.
would just, oh,
Oh no,
sorry.
it's okay. We're gonna keep, I'm gonna keep beating up on Paul. I trust you. I don't trust Paul yet.
I could pass it along.
Yeah, Paul, you're
Um,
surviving.
yeah, I would do, yeah, like Pivens Pavens, just assess that like segment by segment.
Okay. What would you expect to find if this was a lateral stenosis potentially?
If this was lateral stenosis,
Say this is a lateral stenosis, and we'll give you bonus points. I'll say this is a lateral stenosis caused by a subluxation.
so I guess determining like the direction of the subluxation or which direction it's not moving
Yeah.
into.
Yeah, you could think extension is closing the foramen, but when you get a degenerative disc like this, the axis of rotation isn't always very clear in the center of the disc or where it is. So it could potentially find flexion, but I would think something of extension would be more limiting and
Okay.
closing off the foramen, which would be a little different than the disc model we saw earlier. Even if we're getting radicular symptoms, and this could be a 56-year-old female who presents with recent history of somatic referred, right, upper extremity pain, who recently developed paresthesias or radicular symptoms in her arm without pain. Like that would be kind of indicative of lateral stenosis. It's a slow progressing process.
Okay. Yeah.
So we can see that. While you're doing so well, let's say it's not the anchovertebral joint, but we have a lateral stenosis. And this 56-year-old woman now, what are the likely causes of this lateral stenosis?
Hmm.
One of which is in the list. Actually, two of them are in the list.
What's yeah, I guess like the ligament, like ligaments, maybe the bone itself, like arthritic changes to the bone.
Where those arthritic changes likely be occurring? Two spots on the list.
Uncovertebral joint.
Yep. Yeah, very common. It's going to encroach into the canal, arthrosis that occurs in the anchovertebral joint, and also, spurring off the facet joint, two bony structures that can do it. And Bogduck wrote a lot on the spine, and over the last 30 years, he talked about in one of his articles in Cervical Science, he talked about like soft disc lesions and hard disc lesions. I don't hear this terminology thrown around too much, but it is nice to see in that when you're under 50, you tend to get these soft disc lesions. It's the disc itself that can do this. And then as you get over 50, you tend to be what they called hard disc lesions, which are the bony ingrowth into the canal. So the fact that she's 56 kind of tells me that, okay, I expect her to probably have maybe a lateral stenosis with potential hard disc lesion. I'm expecting to find in her when I see this that, okay, she'll probably have an anchovertebral joint, which is moving kind of cranky, if moving at all, and probably some facet arthrosis or some capsular pattern from some changes at the facet joint. So when she walks in the clinic and I look at her age, look at this, yeah, I'm going to be thinking, I'm hoping it's lateral stenosis. And that versus an acute disc, which an acute disc should be hopefully it would be more painful. So that she could have the same paresthesias and symptoms into the arm, the acute disc, if there's disc inflammation, is going to be a lot more angry. And this is more of a slow burn. That makes sense, Paul?
Yep.
Well, I know all of you are reading ahead and thinking, oh crap, I just read these next two cases and they seem harder. Yeah, we'll look at a lot of anchovertebral joint picture, the angle of it. We're going to talk about the aging and biomechanics of those a little bit later on. All the problems we'll find, you'll probably see will be in more of the anchovertebral than the facet joints, where you see your pain patterns when you kind of get into it and you feel the stiffness of the motion as we do it. Hey, Justin, your patient's a 41-year-old male. He unfortunately was in a car accident, and you're noting acute pain and splinting of his neck following the MVA. It was a rear end collision. Pain was immediate and moderate to severe, but he went home, didn't get any better. And instead of going to the ER, for whatever reason, he called you up. What are you thinking, Justin? Are you out there, Justin?
I'm
Oh,
here.
he's unmuted and thinking. Talk to me about this one. What are you
Um,
thinking?
well, I would want to rule out fracture,
Mhm. What makes you think
which
fracture?
because of the mechanism of injury.
Hmm.
Um, and then he didn't go to the ER after the accident, correct? You said?
Hmm.
So
Yeah.
he's had no imaging done, which I would want that done first before doing anything.
What would make you want
Um,
what things would make you want the imaging done? Like any patient, like you get this rear end collision, thinking like Canadian C spine rules, which I put in the bottom for everyone too, just in case you kind of forget them. I like to review them every now and then myself.
limited range of motion.
Yeah.
I
Splinting. Yeah, it's an obligate loss
yeah,
of range of motion. And it was acute too.
yeah.
The immediateness of it, right?
Hmm.
So we have acute
Uh,
pain, severe splinting, and severe pain.
yeah. After
Now,
that, if fracture was ruled out, then I would probably go more to
mhm,
like a whiplash muscular related.
mhm. Yeah. So let's do that. Now, if we had a fracture, what fracture would be most probably? What's one of the common fractures you might see with this one? What would you think?
Um,
And say it's in the upper cervical region.
Probably the could be wrong on this, but like the dens.
Yeah, the dens is one that you might see with this if it's at that forward position. Justin, what's more likely to happen? Is it more likely that the transverse ligament is going to tear, or is it more likely that the dens would fracture?
Probably the ligament tear.
I know, isn't that what we all think? But it's actually not true. But in our
No?
minds, it makes sense. But what happens is because the transverse ligament and the ligament structure there is so strong that it's more common for the dens to fracture first at the base, which I think is type 2, than it is for the
Okay.
transverse ligament to tear in the severe pain. The transverse ligament tears you see, it's usually somebody with some predisposition, some systemic arthropathy, Down syndrome, or something else. So that's where the dens fracture is actually the more common finding than the transverse ligament. But it's easier to teach transverse ligament stress test to us. So we all do that, and that's what we're kind of geared toward thinking. But it's just nice to know that it's more likely we're probably gonna have is the other one. And they probably never get to us because of the severe pain and splinting and things that scream out to you. So that's good to know. If you see this individual, they may not be thinking, okay, I want to do a sharp purser to see the transverse ligaments intact. It may be thinking more, okay, do I know better? Let's make sure you don't have a dens fracture.
Mhm.
Okay, let's say, again, change it a little bit. And you were talking about before, your second one was going to be a post-flash associated disorder. Tell me, again, what you would expect that to be if the person came to you 48 hours later. What's that person look like?
I would still say limited range of motion, um, muscle guarding. Um, I don't know. Those are kind of the only two things that come to mind.
Okay. And that can be a very wide bucket of symptoms. And I included some of it below, and then you can kind of say, okay, it was post-concussive. If there's an element there, it gets even wider. But you're right. What are the potential pain sources in individual whiplash? Now, I recommend doing is scanning your eye up to number 4 and looking at that list, maybe eliminating one of them. but what is the most common source of pain in the mid-cervical region in a whiplash associated disorder? You just got to go through it, Justin. It's nothing fancy. It's not a trick question.
Wait, can you repeat your question again?
One, what do you think is the most common source of pain? And then two, let's talk about the pain patterns. What are the different structures that could be generating pain in this individual? What do you favor
So
here?
the pain,
Yeah, let's take the list from number 4. Facet joint. Is a facet joint a potential source of pain in the whiplash associated disorder?
yeah.
Yeah, and in some cases it's considered to be, I think, number 1. In that it's a very commonly injured joint, and you get like a Jim would tend to call like a traumatic arthritis or inflammation of the joints, or the capsules can get torn around the facet joint, the trauma to the joint. Justin, what do you think happens to the surrounding musculature when we get a facet joint that becomes irritated or capsules that get torn?
Then there would be muscle guarding around those areas,
Mm-hmm.
increased muscle tension.
Uh-huh. It can be variable. What would you likely see? What are the options you might see? It's really both options in the deeper muscular system. Let's say that we're going to call it the deep multifidi, and to some degree the semispinalis, but mostly the multifidi.
I mean, they could either turn on or shut off.
Here, reflexively, there tends to be an inhibition that goes on in them, and a turning off, with an upramping of the superficial muscle groups. What occasionally happens in there, and they see this in the brain imaging studies, is that in these chronic cases, what happens is deep multifidi and the superficial multifidi start to work more like back extensors than joint stabilizers. Their firing pattern changes. It fires later. It tries to act more like an extensor. So in dysfunctional, patterning after lumbar and cervical injury, you'll actually see that brain map and how we recruit those deeper muscles changes, and then that becomes problematic in the firing. But the more common thing you tend to see in these chronic cases is, actually, I don't want to let you do all this work. I think Lauren wanted to tell me, Lauren, what happens to these multifidi muscles when we've had facet joint irritation or arthropathy due to a car accident? What's one of the bad things that can happen to them? Just tell me everything they told you in school, Lauren. Oh, Lauren's off having lunch. All right, bad news, Laura. You're next on the list.
You said what happens to the multifidi?
Yeah, what happens to the multifidi in a subacute or chronic individual with whiplash associated disorder?
I guess increased tone of the muscle.
Now you get the superficial tone. What tends to happen is that these muscles will start to atrophy and get smaller, and the muscle fiber type will actually change in them. They go from like a type 1, I believe, to a type 2, if I have that correct. And you get fatty infiltrates and fibrosis. And if it goes on long enough, that muscle is replaced by fatty infiltrate and fibrosis, and they lose the abilities. That's the problem with some of these chronic whiplash associated disorders, is that the muscle type changes, you get these fatty infiltrates, it's fibrosis, and then a year or two later, you don't have the ability to rehab the multifidi muscles because there's been a great deal of change. In acute neck pain or subacute neck pain, I mean, it could be one of the problems that we see is that, hey, if it's a facet joint problem and I go ahead and manipulate the facet joint and fix the subluxation, but the recruitment pattern stays altered, then they can be back in 6 months or a year, but then those muscles can start to atrophy and kind of change. So, like, part of our rehabilitation program needs to know that, yeah, I fixed your acute pain problem and you're feeling better. But we also, to a degree, need to make sure that, hey, I know from the numbers that this process happens. You need to have some type of strengthening stability program, something to do to try and recorrect this so you just don't become a chronic reoccurring person. I believe that process can set in fairly quickly with with individuals who are sedentary in this thing. I forget the exact dates. I know they've seen muscle atrophy in some studies within a week or two. But the change in muscle fiber thing could be fairly quickly. Yeah, same thing. You see brachial plexus injury, which is good. So you'll see that same problem. I'm surprised it's not faster with a brachial plexus injury unless it's overlapping. Go ahead.
Well, Dave, if you want to hear about how fast it happens in a brachial plexus injury, we can talk about that on Tuesday. I can send a link on a talk that's being given. But
Please do.
I actually had more of a chicken or an egg kind of question.
Yep.
So, my lens is a lot in brachial plexus and lumbar plexus injuries. And so for that, I worry about fatty infiltration when it comes to nerve transfers, knowing that from time of injury to 1 year out, that's the most progress I have to make with my patients there.
Yeah.
So when we're talking about something like a whiplash associated disorder, are we more worried that is it a chicken or an egg situation? Like, is there an initial acute trauma to the nervous system that can then cause this cascade of fatty infiltration? Or is it more of a facet muscle positioning problem that can then later cause this cascade of fatty infiltration?
Yeah, and pretty liberal now as I get older. I try not to be as dogmatic about what I think things are. Like in this case, it's a bell curve probably in some way, or a smudged line, like a smudged homunculus is what it is that who's having it, because now that I have the chronic arthrosis in the facet joint, I'm getting reflex inhibition or pain inhibition that's driving it. And then my brain map changes. So the brain map, you can consider that neural, but I consider that maybe central. Is there local pain or local reflex inhibition going on, which is probably again driven from the facet joint? That may be more of a neural spinal cord level. I think you're getting these different things that kind of can happen in there. If the muscle itself's been damaged, another thing I've seen too is that there are 4 layers. If they look at the cervical muscles, and there's 4 layers of them, and what separates each layer is a rim of fascia, much like the thoracolumbar fascia that surrounds the multifidi and the longissimus and iliocostalis. There's 4 layers that have a fascial sheath, and that fascial sheath creates a tight tension tube that allows each individual group of muscles to function properly. One of the things that happens in some of these chronic whiplash associated disorders is there's a tearing of that ligamentous tube, that fascial tube. So you can look at it under ultrasound, and when they do it under ultrasound, they'll see that when that person goes to contract, say, semispinalis capitis or cervicis, that tube, that ligament pulls away, it doesn't create tension, and that muscle can't create the right length tension relationship. So you get a pain pattern from either the ligament that is not optimally attached or the disruption in the proper muscle firing. That's pretty technical stuff, more technical than I thought I'd go into today. But you'll see these things go in, and as we talk about that, it's fun food for thought to think, which one is this? And can I see it? Now, we don't have the ability to detect, okay, was there a surrounding fascial tear? What we have to do, and if there is, we're still left with the same treatment patterns of how can I properly maybe rehabilitate these muscles and positions to drive a more normalized pattern and create hopefully some hypertrophy or retraining. But no, be fun. Please send me the link.
Yeah, so just so I understand, so you're saying that the muscle in and of itself can have damage causing a fat infiltration, but also some level of a nerve denervation can also cause a fatty infiltration, leading to ultimately atrophy.
Yeah. And it's kind of like you can work it back from multiple systems. We can pick one of these things up here and kind of figure out if I think facet joint, absolutely. And there's been tons of studies done in the lumbar spine showing this. They inject saline or the noxious stimulus into the facet joint. Multifidi muscles change immediately, and they don't always go back. So many times within a couple of hours, the multifidi muscles rebound and they're back to their normal function. Other times when they irritate the facet joint problem resolves, but the muscle recruitment pattern does not. It is either that feed forward mechanism from let's say from the brain, the feed forward mechanism is altered, or the local reflex response has been altered. You get under recruitment of the multifidi, so they start to atrophy. Or the brain then kind of remodels them to operate more like long extensor and less like a joint stabilizer. So the brain can remodel changes kind of functional pathway, and then that becomes problematic because now it's not preemptively firing to stabilize the facet joint. That's a common problem that you may see with some of the chronic whiplash patients. And where we may get them is usually not right after the car accident. You're seeing this patient 2, 3 years, 5 years later, and you're dealing with what has been kind of left over from that initial accident. And that's where, it's good to understand it. You can't change some of what happened, but understanding what's happened, why it's happened, at least it helps you with the direction, expectations. How do I get this person more comfortable? And we'll go into a lot of the tricks in doing that. Like, a lot of what we have to do here is you need to have the foundational information. When you get to clinic, it's like, okay, what's the bag of tricks we have that's that clinical skill that's not necessarily written clearly in the textbook, or how do we apply things from multiple people to come up with a unified theory? That's what the labs are. Really, we want them to be about that portion of that skill level. The didactic stuff we want to have solid because it gives us that foundation for that skills. Who's having fun? Who's having fun? John Kerry's having fun. Because he was wondering, man, am I going to get a chance today? And luckily, he popped to the top of the list.
Of course, I'm having fun.
Yeah. Okay, here we go. Patient 6 weeks post-op NVA, noted neck pain was moderate after the accident. No ER visit, just an MD who prescribed muscle relaxers. She noted cervical pain, irritation now with office work and being at work, mild dizziness at times at the end of the day. This.
Initially, I kind of think muscle related. I'd like to see how she reacted to those muscle relaxers. Just because of the motor vehicle accident and then dizziness towards the end of the day. Not quite sure how that fits into things, but I'm guessing more of a tiredness in those muscles or aggravation throughout the day. But I'm not sure where that dizziness portion comes in.
Yeah. What do we need to know more about dizziness?
What
Tired
kind of
muscles is something.
what
Yeah.
kind of dizziness?
Yeah. Yeah. What type of dizziness do you suspect this would be?
Non-vertigo related.
Yeah. And how would that patient describe that dizziness?
More of a spots in the eyes, not really like room is not spinning.
Yeah, it's gonna be more of a disequilibrium. They just feel off. Not necessarily malady embarkment, but they just feel kind of off, or swaying in a sense. What you're looking for with this. With that, and again, you can explain the muscles to me at some other point. Let's say if this was articular, what would likely be the levels that would generate this dizziness?
Upper cervical.
You got it. Good job. You're paying attention. Good. So why would she potentially be getting this dizziness and the irritation later in the day as an office worker?
Like position of her neck throughout the day or posture of her neck throughout the day while she's working.
Mhm.
More of that forward head posture.
Mhm. Okay, so any questions you'd like to ask her? Let's say you asked her about the dizziness already, and it's non-vertiginous dizziness. Any other questions you'd like to do? And what is your H1, by the way?
H1 is probably a segmental dysfunction that is being almost exacerbated by tight muscles, keeping her cervical spine in that position.
John, you're a muscle guy, aren't you?
I am a muscle guy.
Yeah, I can tell. Okay. I'm just judging you right now. Give me a second. Okay. I'm good. Yeah, okay, good. So what do you want to do next? What test would you do?
Start with just general range of motion, see what possibly elicits either her dizziness or her neck pain.
Okay, right side bending, right rotation.
So I'd probably go more to testing the facets and seeing how they're gliding laterally. And see if that elicits any of her pain.
Okay, which facets are you going to test?
I'd probably start lower cervical and work my way up her neck towards where I would suspect the problem is in her upper cervical.
Okay. How would you test? Tell me, how would you go about testing this? And I'm not judging you because we haven't covered any of this, so just give me what you have, John, and I'll be kind.
What I've been working at, or what I was taught through one of my clinicals, was a lateral glide, blocking the superior vertebrae and gliding the inferior vertebrae.
Which
Almost.
level?
C3 through 7.
Good. Is the headache coming from C3 through 7?
No, probably not.
Okay. Would you do this at C1, C2?
I would do more of a unilateral PA at C2
Okay.
to test and see if it created any headaches.
Okay. Let's say the pain is on the right side. We had pain with right side bending, right rotation. If it was C1, so on C2, what would you expect the limitation to be?
Like in what direction would I expect to see
Yeah.
the
What
restriction?
direction can't this joint go? You know, can make it simple. Anterior, posterior.
Anterior?
Oh, you're so close, John. You're on a roll.
Posterior.
There you go. That's it. You know, it's different. It's sort of training. It's kind of a trick question because C1, C2 is a rotary joint. Unlike the other facet joints where you kind of think of more classic flexion or inferior glide, is it's a rotary joint because we have one one convex surface kind of mounted on top of the other concave surface of C2. So when I'm rotating my head to the right at C1, C2, it's the flexion rotation test. The right C1 facet is generally gliding posterior and down the surface of C2. My left side is gliding anterior and down the left surface of C1 at C2. So what it would be is for me to turn to the right, you can turn your head to the right, think of it as a posterior glide of C1 on the C2 facet joint. So if it was, for whatever reason, stuck anteriorly, lacking that glide, it would do it. But I'm gonna throw you a bone, John. There's a little bit of muscle tightness around there. But that joint, but it's a muscular guarding end feel of that joint. How about C2, C3? How would you test C2, C3? And what restriction do you think? Well, it doesn't really, you can make an argument for either restriction, but tell me a little bit about what you would expect to find at C2, C3.
I would expect some restriction in the more anterior direction due to the posterior restriction, C1, C2. I'm
And
not
stuck
sure.
anterior and won't go posterior.
No, it's stuck posterior, won't go anterior.
Yeah, quite honestly, John, you could probably make an argument for either one. Like before seeing that anything else, I probably think that okay, can this joint not extend because they're getting pain when I'm trying to extend into it? But that said, you know, if I damage the facet or the capsule, this joint was hypermobile into, you know, into extension at that point or got damaged, then going into extension could be painful. So it's like I know this, I kind of have an idea of okay, this is what I think it may be, but I keep an open mind knowing that hey, I haven't touched this yet. I have no idea the quality of motion of this joint. And that it could be that I know that this probably is going to be 2-3 that's painful for the irritable joint, but but I don't know that quality yet, so I'll get in there. So you can go either way with it, John. So extension could be with that I might expect that, okay, this joint got traumatized and maybe I, irritated in that way. And that's gonna be traumatic arthritis with muscle guarding. If it was subluxed and limiting right rotation, right side bending, then I expect it to be subluxed into flexion, not allowing extension of the joint. But that's pretty high level, John. We're kind of really ahead of ourselves chatting about this. So you're doing fine as we do this. Let's say this was muscular. And since you're a muscle guy, John, I have C1, I have a muscular end feel and I go to right rotation of C1 on C2. Which muscle would most likely be hypertonic in limiting the rotation of that motion in the upper craniovertebral region?
The splenius cervicis.
Potentially, but splenius cervicis is a pretty superficial muscle. Is there a deeper muscle which, if hypertonic, would be more likely to limit that rotation of the one segment on the other? Because the vector of pull, the splenius cervicis, is pretty far away from the axis of motion. So I should be able to glide it. Which suboccipital muscle? And if anyone's on the board, because I'm torturing him now, and wants to help, feel free to help.
Yeah, I'd love to phone a friend on this one.
Yeah, it's no problem. And again, not knowing this stuff is hard. These are hard questions, John. And you've done you've done a good job. So don't feel all beat up. Now I'm just amusing myself now. Yeah, think about again the rectus capitis, inferior oblique in the rotation, and you'll see that, and you'll see tone. So, if I'm seeing somebody who has a muscular restriction with right rotation, I'm going to palpate C1, C2, and we're going to do this in lab probably on Saturday. And we're going to look at these suboccipitals and say, hey, is this suboccipital tone? The joint appears to glide, but I have a muscular end feel. Now we're going to get specifically into which suboccipital muscle may be the one driving this. So it'd be probably the left. If I'm hypertonic in my left rectus capitis inferior oblique, that's a left rotator of C1 on C2. It's hypertonic. I'm going to get a muscular end feel with right rotation. So it's cool. On Saturday, what we're going to be able to do is we're going to look at these muscles and see how that may be the limiting factor with right rotation. We're going to look at the joints and see, okay, is it a painful joint that doesn't want to extend on the right? Or is it a flexion subluxation of C1 on C2 or C2 on C3 that may not be that in this chronic MVA patient would do it? Most classically, what you'll see in this person, this will be and probably maybe an extension subluxation of that's irritable on C1, C2 on the right. But it could be a flexion subluxation just as easily doing it because she can't extend as she goes to forward head. And then the muscle's overstrained. So it's kind of having an idea what we're going into and teasing through it. But all the details on these individual cases are below. I didn't read it over because I just read all the details below. You'd be bored out of your mind. But if you look at a case and what we did, having an understanding of these concepts and these different illness scripts or these conditions below allows me to tease through these cases quick. And I think everyone here did a great job today. I think it was well done, especially without getting it in advance. Cool. I will have next week up sooner. Let's see if I can see what we're doing next week. Give you a heads up. Sorry, I'm working on 1,000 things. Mechanics next week. Yeah. Well, have yourself, John. You did good. I'm gonna post some stuff on cervical biomechanics, and we're gonna do upper cervical spine. We'll get into more detail on what John and I discussed next week. It'll be fun. Take care, everybody. Thanks for your time.